Hi, everyone. Welcome to the webinar. I am Alicia Barron, and I'm the Education Manager for Texas and Louisiana, and I am delighted to be joined by Dr. Matthew Hamilton. Dr. Hamilton is the Director of Translational Research at Brigham and Women's Hospital, the Crohn's and Colitis Center there, and his research focuses on characterizing the many phenotypes of IBD, both the clinical and molecular level, in order to establish personalized therapies, exactly what we're talking about tonight, so it's perfect. And although he's gained national recognition for his clinical and scientific expertise in IBD, he's most proud of his patient-centered approach to care practiced at Brigham and Women's. I can attest to that. You're an excellent doctor. And you've also been an active member of the Foundation CMAC for 8 years, and you were the chair of the CMAC for 2. You've been a speaker for us multiple times. You've been a panelist in national things and also local things, and also you were recently honored as a Humanitarian of the Year at the Crohn's and Colitis Foundation New England chapter's annual Fete of Food and Wine. So we are very excited to have you, as you can tell. Before we get started, though, I want to do a quick shout out to our sponsor tonight. This webinar is sponsored by UCB, so thank you so much to UCB for sponsoring this. And just a little bit of housekeeping. So I'm going to take myself off the screen soon, and Dr. Hamilton will share his slides and tell you a little bit more about himself. And then after he is done speaking, I'm going to bring myself back up, and we're going to take questions from everybody that's out there. You're going to see there's a question box that's in that little GoToWebinar deal. You're going to type your questions there, and then I'm going to ask Dr. Hamilton. So please do type your questions there. You're welcome to type them as we go, but we'll take questions at the end. So I will just find them there when we're done. So Dr. Hamilton, I'm going to turn it on over to you.
All right. Yes. No. Thank you very much, Alicia, for having me involved this evening with the webinar, and to be able to speak to all of you tonight about something that I'm pretty passionate about, and I've really dedicated much of my career towards. That's taking care of people with IBD, and you know, and not really just taking care of people. I'm really trying to, you know, again, do that in the clinic individually, but then also take it to the next level as well, where we can try to make some discoveries that are going to affect the broader population of people with IBD. So, as Alicia alluded to, I've been doing some work at the Brigham and Women's Hospital now for over a decade. What's called translational medicine. So you may have heard that term before, but it means that we're taking what's going on in the lab with really on the basic science level of things, and we're trying to take those discoveries and take them to the clinic where we can take care of people. So for instance, I'm looking for biomarkers for disease of the disease, so that you know, we can create new tests that allow us to be able to treat individuals better on a more individual basis. It's not an easy task. It's a lot of work, but you know, I think it's really the way the field is going. We need better tests. So, you know, I'll talk about this towards the end of my talk. But it would be great if we could be able to test what your sort of overall risk is, what your prognosis is. When you get diagnosed, it'd be nice to do a test to say, oh, you have this type of IBD. You know, you're mild or moderate or severe, and you're going to respond to X, Y, or Z therapy. You know, that's sort of where we want to be to, again, provide what we like to call personalized medicine. So anyway, what we wanted to do tonight was to have me go over some slides where we review a lot of the basic tests that we do in IBD. I think oftentimes you may be thinking, you know, why is my doctor doing this? Why do I have another one of these tests? What does this mean? How is my provider team using all this information to help me? You know, I think that can be confusing for a lot of people. And to be honest, I think a lot of us, the providers, don't do a good enough job explaining things to you so you can understand it. So I was hoping to run through a lot of the basics of what we do in the clinic in terms of testing and what it all means, and sort of what goes through the provider's mind, and hopefully will help you. There are 20 slides, but I think we can run through this in about 20 minutes, 30 minutes. And then, as Alicia said, have some good time for questions at the end. So we're going to start by sharing my screen here. So hopefully you'll be able to see my slides. Alicia, let me know if this is working okay and you can see my slides.
Yes, I can see your slides.
Okay, perfect. All right, so I'm going to make this bigger. And then can you see my marker too?
Yes.
Yeah, okay, perfect. All right, you know what? I'm going to start from the beginning. Sorry about this. You get to see all my slides. I'm giving it away here. Okay, here we go. So the title of the talk is Getting on the Right Treatment Plan for Your IBD and Why All the Tests. Okay, so this is really the key slide here. So this is actually the same slide I give to our trainees when sort of teaching them about IBD and how to take care of people with IBD. So how do we decide on the medical plan? Really, when you're trying to upfront decide on the medical plan, you need to factor in these things. And the first two are probably the most important. So what is the IBD disease severity, number one? So, how bad is the IBD at this sort of point in time when you're in the office, when you're first being seen with this? Number two, what is the risk, or otherwise known as the prognosis? So when, we like to know what kind of IBD you have and what the risk of your IBD is for the future. And where is your IBD going to go? So what's going to happen in 6 months? What's going to happen in 1 year, 10 years? We like to factor that into our decision when we're trying to come up with a medical plan. Third point there is when we're trying to come up with a medical plan, what medical therapies have you been on? I'm at a referral center here in Boston, so I see people that have already been tried on several things. So I like to have that history. Number four is more history about you, the patient, your other medical history, other medications you may be on, and really what's your preference, what medications do you want to be on, do you like injectables, infusions, oral medications? That all has to be factored in. Unfortunately, the reality is there's this fifth point here, which is, the insurance providers, what's their preference? Again, this sort of varies in terms of where you are, but and I can tell you in the Boston area, the various private insurance companies and providers like Medicare will have their sort of preference in terms of medications that can be used. So we had to factor all these things in. We're going to talk several slides about how we assess disease severity and then how we assess prognosis. So how do we assess disease severity? So again, this is how bad is the IBD at this sort of given point in time when you're trying to do your initial assessment. So we base it on a couple things here. So symptoms, and then some of the lab tests we do, and then some of the other tests we do, which most importantly are endoscopy and colonoscopy. So symptoms, so as you are all well aware, the main symptoms are stools and abdominal pain. So we ask you all these questions about what about your stools? Like, are you having stools at nighttime? Are you having a lot of blood in your stools? How frequent are your stools? This can sort of give us a clue about how severe your IBD is. Abdominal pain and cramps. If you're having daily abdominal pain, that's a sign that maybe you have more significant IBD. We also ask you about so-called systemic symptoms. So these may be symptoms outside of the GI tract. So are you having fevers or weight loss? That's a sort of sign that you're systemically just not well. You have this chronic inflammation in your body, and it's affecting these other things, which again can be a sign of severe IBD. Labs, I'll tell you later what those labs are, but we do want to make our assessments for evidence of systemic disease. So lab tests can tell us, are you anemic? Are you malnourished? That would, again, let us know that maybe your IBD is a little bit more severe. So labs can be very helpful in this assessment. When we assess your IBD with an endoscopy or colonoscopy, your provider is looking at certain things to help us. So we can basically tell you after an endoscopy or colonoscopy a ton about your IBD. And I'm going to show you some slides in a minute, but not only what type of IBD you have, but where is it and how severe it is. So there's certain things we're looking for. And again, I'll show you pictures. Ulcers are one thing. So the size and type of ulcers, whether or not you have some of these other features, like particularly in Crohn's disease, we can see things like strictures and fistula. These things can be markers of pretty severe Crohn's. And we also want to think about the type of Crohn's that can tell us about the severity of Crohn's. So there are different types of Crohn's. There's the so-called penetrating or fistulizing type. We think that's a sort of more severe form of Crohn's than some of these other types. It's just stricturing and just the garden variety inflammatory type of Crohn's. It's just depicted in this picture here. Inflammatory type of Crohn's, again, this is sort of like a milder form of Crohn's where there's just inflammation that's just really in the lining, inner lining of the intestine, as seen here. Stricturing is when you start getting this narrowing down, the scarring of the intestine, which is sort of a higher severity form of Crohn's. And then the probably highest severity form of Crohn's is the so-called penetrating or fistulizing Crohn's, where you get these connections between different things like different parts of the bowel or bowel out to the skin. This is called fistulizing or penetrating Crohn's, which is the most severe form of Crohn's. All right, so we talked about severity and how we assess that. Remember, symptoms, labs, endoscopy, colonoscopy. But what about the other thing we want to look at, which is risk or prognosis? So there are some things we look at. So, and it varies a little bit between ulcerative colitis and Crohn's. So with ulcerative colitis, we do know on the left panel here that there are certain high risk features. When your whole colon is involved with colitis, that's a higher risk feature than when maybe just the rectum is involved or just maybe the left side of your colon is involved. So again, we'd like to know what the extent of colitis is within your colon. Whether or not you've needed steroids to treat your colitis is also a risk factor. So if you need steroids right from the get-go and several courses of steroids, that's a high risk feature of your colitis. Whether or not you have the evidence of systemic disease again, so anemia, that's a high risk sign. Ulcers on colonoscopy is depicted in this picture here. If you've never seen the inside of a colon, this is what we're looking at here. So we're looking sort of down the channel of your colon here, and this is basically entirely made up of ulcers here. This colon, this particular picture of this colon on the left-hand side here. When we do biopsies, sometimes the pathologist will tell us that it's severe inflammation, and that's also helpful. That's high risk. Low risk, so again, as I said, limited colitis, so maybe just in your rectum and not the entirety of your colon. If you haven't needed steroids, if you don't have anemia or malnourishment, and if the endoscopy is milder and the resulting pathology, those would be lower risk colitis features. Switching to Crohn's, again, slightly different, but similar themes. So on the left here, high risk features of Crohn's disease. Remember, with Crohn's disease, that can involve not only the colon, but the small intestine as well. So in fact, when it does involve the small intestine, you may have heard the term ileum before. That's a common place for Crohn's disease to be. This is, we think, is a higher risk feature of Crohn's when it involves the small intestine or ileum. People that have this are maybe high risk for surgery. Deep ulcerations seen on colonoscopy, that's a high risk feature. People that have Crohn's in their younger ages, and especially around the time of diagnosis in the 20s and 30s, this is considered a higher risk feature. Again, whether or not you've needed steroids, whether or not you have involvement in the perianal area, so people that have fistula around the anal area, that's a high risk feature of Crohn's that we worry about, and we want people to be on pretty aggressive treatment if that's the case. Systemic disease again, and whether or not you're an active cigarette smoker. So if you are a tobacco smoker, that's considered high risk, just given how that can affect the disease. Low risk features of Crohn's, believe it or not, it's involved in just the colon and not the small intestine, and then other features that we see on colonoscopy, so different forms of ulcers, so not those deep ulcers that we would see with the higher risk, such as this picture here. This is a deep ulcer, but more sort of superficial, aphthous-looking ulcers. That's a low risk feature of Crohn's. All right, so thinking about this in terms of risk and severity. Okay, so what are the tests we're going to do to get at how severe your IBD is and what the risk prognosis of your IBD is. Remember, we're trying to sort of gather all this information so we can come up with the best treatment plan for you. So, before we even start with the testing, your provider hopefully is spending a good amount of time talking to you and getting the so-called history. So not only your medical history, but everything about your IBD history, symptoms leading up to this time of diagnosis. If you've already been diagnosed, getting everything about how that diagnosis was made and maybe medications you've been on. Physical exam is always important to look for any sort of complications or anything else that may be important in terms of treatment. Lab tests, we sort of talked about this a little bit, but we mainly hone in on a couple of things here, and many of you are, I'm sure, familiar with some of these tests that we do. So one of the things we like to do is look at what the current state of inflammation is associated with your IBD, sort of objective evidence of where you are with the IBD. So we get the subjective evidence by talking to you and getting the history and you telling us about your symptoms, but the lab test can give us some objective evidence to sort of back that up. So there's the blood test that we can do called the CRP. If that's elevated, that suggests active inflammation. It's not very sensitive in terms of, it may not always be specific to your Crohn's or your colitis. If you have a cold or something else going on in your body, that may elevate your CRP. So it's not the best test, but oftentimes it does correlate with IBD. So we do use it. And it's a blood test that's easy to get. The other test that we're doing more and more these days is a stool test for inflammation called the fecal calprotectin. The drawback is that this is a stool test, not always the easiest thing to get. We have to collect first thing in the morning, ideally, and bring it into the lab that day. But it's a very, very good test to tell us whether or not you have active inflammation, especially with colitis. It's an excellent test for colitis activity. We're actually using this so much now that we can use this test rather than having to do the sigmoidoscopy or colonoscopy. Talk to your provider about doing some of these tests if they haven't done them to detect inflammation with IBD. As mentioned, we also like to do lab tests to make sure you're not having evidence of systemic disease. If you have severe IBD, so we're looking for things like anemia. We do a test for what's called albumin. That's a good overall marker of your nutrition state. So those are some of the basic lab tests we do. As mentioned, the colonoscopy and biopsies is a very, very, very important test. So this is probably the next big thing we do, oftentimes around the time of diagnosis to make the diagnosis, but then later, if you have a flare or something changes about your IBD, and we really want to know what's going on inside, we do the colonoscopy and biopsy. So ideally, we're getting all the way around the colon with our scope, and then even up into the last part of the small intestine, the so-called ileum. We're looking at what we see, and then we're trying to biopsy all the different segments. So we have all that data in terms of what we're seeing and what we're seeing, pathologist is seeing, and then we're going to put all that together to tell us exactly where your IBD is again and how severe it is. And again, I'll show you some pictures in a minute. The other testing that, again, I'm sure you're all familiar with and that we do is the so-called cross-sectional imaging. So this is radiology studies. It can be very helpful in IBD. So most often nowadays we're doing MRIs. We used to do a lot of CAT scans, and CAT scans still are done. We're trying to get away from that a little bit just because of the risk of radiation. But MRIs are excellent tests to tell us what is actually going on above the areas that we didn't get to with colonoscopy. So that's oftentimes why we're doing MRIs. It's the so-called enterography, where you have to drink a little bit more contrast, which is not always the most pleasant thing. But that gives us excellent pictures of the small intestine to tell us, do you have any evidence of IBD higher up in the small intestine that may be leading to your symptoms? It can also tell us, do you have any sort of complications up there, sort of like strictures, scarring, fistula. We can evaluate all this with our radiology studies that are excellent. We can also do image the pelvic area to assess for any sort of fistula or abscess or complications in that area. So oftentimes what we're doing is a combination of all these things, really, lab work, colonoscopy and biopsies, and the radiology study to really know exactly where you are with your IBD. So we have all the best information, and then we can determine the treatment plan. Just some pictures again, and to show you, some of the testing we're doing. So this is some endoscopy pictures and what we may see. So this is ulcerative colitis, and we sort of, again, if you haven't seen the inside of a colon, this is what it looks like. So top left picture here, we're sort of looking down the so-called lumen of the colon. It should be this sort of pinkish yellowish color. You should see blood vessels. This is all beautiful normal colon. But then in colitis, you can have different stages of severity potentially. So we have mild, top right here, moderate, bottom left, and severe, bottom right. So mild is like sort of more red, and you can see it looks a little bit more swollen. Moderate colitis is when it starts becoming what we call friable. It may actually bleed as we're going through with the scope. And then severe on the bottom right here is more ulcerated, as I showed you an image earlier. Hopefully you're not eating dinner while you're watching this webinar. So these are what the endoscopist, this is what they're looking at, and this is what they can tell at the time of your colonoscopy. Yes, you have colitis, it is mild, moderate, or severe, or it's normal. And then they're going to tell you also where it is. Is it in your rectum? Is it just the left side of your colon, or is it the whole colon? So they can tell you all of that. They'll also take biopsies, and we suggest taking biopsies in the different segments of the colon to sort of map it all out. And this is going to be very important information to verify the diagnosis that yes, this is indeed ulcerative colitis. And then they can also, the pathologist can actually tell us on the microscopic level, is this mild, moderate, or severe ulcerative colitis? So, and I'm not going to. This is sort of just for interest here. This is the lumen of the colon up here. This is the very, very surface of the colon called the mucosa, which is most involved with ulcerative colitis, and then you have the bottom layer of the colon. So this is actually a very inflamed colon. These are all inflammatory cells in here. So you may or may not have seen a pathology report of your colonoscopy, but the pathologist is basically telling us that there's so-called acute features of your colitis and chronic features of your colitis. And in ulcerative colitis, you have acute and chronic features. So, and then they sort of should grade the colitis in terms of severity based on the acute features, mild, moderate, or severe. And there are various ways that they do that. All right, so what about Crohn's disease? Same idea, so you can get a ton of information by doing colonoscopy in Crohn's disease. Same idea, we can get the extent of the disease and severity of the disease. But Crohn's disease is a little bit different, it looks a little bit different. Oftentimes they're more sort of discrete ulcerations, like you can see in this bottom left picture here. As now you guys are pros at this, this looks very normal over here, and then all of a sudden you have this ulcer, basically ulcer right here. This is pretty typical of what you could see in Crohn's disease. But this is a pretty superficial ulcer, and then you could also have what's called aphthous ulcers, these sort of white dots pictured here. These are actually pretty mild forms of Crohn's, superficial ulcers like this. The ones we worry about a little bit more are the picture on the right here, so-called deep ulcers, and you can see this like sort of knife-like ulcer that's sort of cutting through the mucosa there, here, another one up here. This is a poor prognostic sign, as we talked about earlier. When we see this on a colonoscopy, so we don't like to see this. This is a severe form of active Crohn's disease. The pathology report for Crohn's, they're going to tell us about things. Again, the distribution and granulomas is something you may have heard about. That pathologist always looks for that in Crohn's disease. It's just a feature that really tells us that yes, indeed, this is Crohn's disease and not something else. The tricky part is some of the biopsies that we do on colonoscopies in Crohn's disease, they're not always like that specific. And I won't get into that too much, but just a caveat that sometimes the endoscopist may biopsy areas that they think is inflammation, and the pathologist won't be able to see a lot. So in terms of assessing severity, that Crohn's disease biopsies may not always be as helpful as they are in ulcerative colitis, but we still do it, and it still is helpful overall to do the biopsies of Crohn's disease and to be able to interpret those. Just a picture of Crohn's disease. The thing I mentioned about ulcerative colitis is that it really just affects the very, very superficial lining, whereas Crohn's disease affects the whole thickness of the colon. It's sort of depicted here. This sort of like knife-like ulcer that's sort of running down to almost all the way through the full thickness here. So that's a feature of Crohn's that we can see on biopsies. All right, and then I said that the cross-sectional imaging testing is also very important. So MRIs or CTs. Again, we like to use a lot of MRIs. This is a picture of this is actually a CT, but MRIs are very similar. So just to orient you, the head is sort of up here, the legs would be down below, and we're looking right at the inside of their abdomen here. And this is would be the stomach here, and these are all the intestines in the middle. This is the bladder down here, but this is a big piece of the ileum here, which I told you earlier is oftentimes very involved with Crohn's disease, or can be involved with Crohn's disease. In this picture, it tells us right away that, based on a couple features here, the fact that the walls are thickened and enhanced, and all these look like little spokes, wheel spokes, are blood vessels that are sort of engorging these areas. This is showing that this is an area of very active Crohn's disease. And we're getting that information from this CT scan here. So very helpful information to tell us where the inflammation is and whether or not it's active. It can also tell us the imaging about complications of Crohn's disease. So this is actually a scarring of the ileum here. And above it, there's this sort of dilated area here. This may even be stool that's sort of trapped in here. So, again, this can be a very helpful image and test to tell us about complications of Crohn's that we're looking for that may explain symptoms, for instance. This is an image of the pelvis, just to show you that you may see complications such as an abscess, and particularly if you have new symptoms like pain in that area. That the imaging test can be very helpful to help tease that out in terms of what's going on in that area. All right, so moving along here. So we have the tests done now. We have the labs done, the endoscopy, colonoscopy, imaging tests. So now what? How do we factor all that into your treatment? So really, this is the question here. And again, this is what I tell my trainees all the time. It's like, okay, where are we with the IBD? Is it mild IBD? Category number 1, or is it moderate to severe IBD, category number 2? And remember, I told you sort of how we factor that in. It's all based on severity of disease and the risk or prognosis of the disease in terms of how we categorize this: mild or moderate severe. And then once you know that, you're sort of home free in terms of where to go in terms of a medical plan. So for ulcerative colitis, if you have now mild ulcerative colitis, the standard care, standard treatment is really just oral medications, oral anti-inflammatories, the so-called mesalamines. So you've probably heard of these things like Asacol, Lialda. For moderate to severe ulcerative colitis, that's when you're sort of moving on to more aggressive therapies. So immunomodulators, which are, again, you may have heard of Imuran or azathioprine, methotrexate, 6-MP. Or the biologics. So biologics are things like Remicade, Humira, Entyvio, Stelara. Again, knowing what the severity is, mild or moderate severe, allows you to sort of, know what the medication plan will be. So for Crohn's disease, it's similar. So again, if we determine that your Crohn's is mild, you may just need courses of this type of steroid called budesonide. You may need nothing. If you have more moderate to severe Crohn's, this really bumps you up. So you're most likely going to need biologic therapy plus or minus the immunomodulators. So very, very, very important to be able to know, again, what your severity of IBD is and what your overall risk is to be able to, sort of put you into a treatment plan that's going to work for you. All right, so just a few more important points here. So what is our goal of IBD therapy? Like what are we trying to do? So you probably heard the word remission quite a bit. So we're trying to get you into remission. So and there's different sort of terms here in terms of what remission means. What is remission? So-called clinical remission is when your symptoms are down to baseline. So you're hopefully no longer having blood in your stool, you're not having abdominal cramping or pain, your stool is actually formed. You basically are back to where you were before you had this diagnosis. So that's called clinical remission. And then if your inflammatory markers, like remember your CRP tests or your stool calprotectin test, if those essentially normalize, if your colonoscopy, if you have that repeated and it looks pretty normal, that's sort of holy grail. That's what we call a deep remission. When these objective markers are normalized and your symptoms are normalized, that's called deep remission. That's what really we're trying to strive for. It can be tough though to determine whether or not someone's in remission. There sometimes may be discord. Your symptoms may be totally better, but then we go and do the colonoscopy and we may still see ulcers. So, that again would not be deep remission, that would only be clinical remission. And we may, in some cases, decide to increase your treatment, if that's the case, just to see if we can heal your colon even better. Because what we know, especially about Crohn's disease, but also ulcerative colitis, that if we can get you in remission, if we can get you in a deep remission, that we can actually change the course of your IBD. And that ultimately, again, is what we're trying to do. We're trying to get you in remission and then change the course of IBD. I mean, over the years and years and years of having IBD, of having inflammation, on this graph on the right here, the complications of disease may start to mount. Things like strictures and fistula and surgeries and all these things may build and develop more and more so-called complications, maybe scarring and things that are irreversible. So we're trying to sort of head that off with our good medical therapy as quickly as we can, so that we can avoid hospitalizations and surgeries, any other complications, hopefully reduce the healthcare costs and get you back to work, get you back to school, all these things. We also want to keep you off of steroids. We all know steroids are not good for us. All right, another important slide here. And as I was just alluding to in the last slide, there can potentially be discord between how you're feeling in terms of symptoms and where you are actually with your IBD. So it is possible that actually you have a lot of symptoms, you have a lot of diarrhea still, but your doctor is like, no, your colonoscopy actually looked great, or your labs are normalized, but you're thinking to yourself, yeah, but I'm still having a lot of diarrhea. Is it possible that are the symptoms you're having, are they actually related to active inflammation, active IBD or not? So sometimes that leads to further testing, which is why I wanted to show this slide, because there are tests that can be done to help tease this out, and many of you have probably had some of these tests done. So point number one here is, if you're having ongoing symptoms, we want to know where you are with IBD. Do you have active inflammation or not? So we talked about ways to do that. The blood test, the CRP, the stool test, calprotectin, potentially having to do a colonoscopy or radiology studies. Where are you with your IBD? If all those are checking out okay, then we always want to exclude other things. So like, do you have some sort of superimposed infection? In IBD world, we're always worried about C. diff, which can cause watery diarrhea. So you may be asked to do a stool test to assess for C. diff. That would require specific treatment to eradicate that. CMV is a virus that can live in your colon. Really in the more severe forms of colitis, we can see that. So sometimes we have to do the really only way to detect this is by doing a sigmoidoscopy and biopsies, and you can see the CMV virus on the biopsies. And then that would require specific treatment. This is a more sort of rare scenario, but we do test for that in certain circumstances. Abscesses, again, if you're having pain or new symptoms associated with your IBD, we may want to assess with that. Again, radiology studies can be excellent for that. There are a lot of other coexisting issues that you may have that's sort of like indirectly related to your IBD. Something called bile salt malabsorption, particularly those that have had their gallbladder taken out or part of their ileum, small intestine taken out. You can get these things called bile salts, which dump into your colon and cause diarrhea. So we can assess for that if diarrhea is your issue. Fistula tracts may cause symptoms. We want to assess with that with radiology studies. And I'm sure many of you have heard of bacterial overgrowth syndrome, or otherwise known as SIBO. People with IBD could be at risk for that. So if you have superimposed SIBO on your IBD, that could potentially give you symptoms like bloat, gas, cramping, and loose stool. So you may be asked to do a breath test to look for SIBO, and then you could be treated for that if positive. I won't talk about this next one. The last point here is this IBS, irritable bowel syndrome. So a lot of people that have IBD, inflammatory bowel disease, also have irritable bowel syndrome. So just by having had inflammation in your body, in your colon, it sort of puts you at risk for IBS. So IBS is, again, your colon, everything could be actually quite normal and healed, but you have ongoing cramping or loose stools or pain, and it may just be the superimposed IBS, which potentially could just be treated with medications that can help symptoms, things like antidiarrheals or anti-gas meds. You can talk to your provider about whether or not you may have IBS on top of your IBD if you're having ongoing symptoms despite your treatment. All right, another test that is newer and that you may have heard of, and many of you may have had this done already. This is really if you're on the biologic meds or the immunomodulator meds that I talked about, so methotrexate or azathioprine, or the biologics, Humira, the Remicade, Entyvio, Stelara. If your IBD is not getting better on these meds, or you're flaring, maybe you were doing well, but then you flared, we can actually check to see whether or not you're on the right dose of drug. And based on those results, your provider, hopefully, will make a good assessment, and they may change the dose of your drug, or they may decide that your drug actually needs to be switched because the test may show that you're no longer responding to that drug. So this is another test that may be ordered for you if you're on these meds and you're not doing well. All right, I think this is my last slide. So IBD in the near future. So where are we going with this? I talked about in the very, very beginning that this is an exciting time because I think we're going to develop tests that are going to allow us to hopefully predict your future and get you on the best therapy. So again, better ways to predict the course of IBD. So when you get diagnosed, it'd be nice to know you're going to have a very mild course, you're never going to need surgery, or you're going to actually have a more severe course and you're going to have surgery in a year. So if we knew that information up front, we'd be able to get you on the best therapy right away. We also want to develop better ways to predict your response to therapies. So, as you may know, and many of you have experienced this, right now it's a little bit of guesswork when your provider puts you on medication. We don't always know how you're going to respond. Unfortunately, the sad reality is many of our best therapies, they only work for 50, 60% of people. So, there's a good percentage of people that don't respond to the medication, but we don't know that up front, and we have to try it to know. So if we can predict how you're going to do up front with a blood test, with a biopsy test, that would allow us to be able to get you on the best therapy right away, right from the get-go. So again, this is something we're sort of all striving for. And this last point here, of course, we want to make sure that everyone has access to all these things we're trying to do. So obviously the best medical therapies we all need to have access to, but also the testing. As you all know, these tests are not cheap. MRIs and lab tests and stool tests and colonoscopies, these things are expensive, and we, in order to best take care of people, we need to be able to have everyone have access to these tests so that we can best take care of everybody. So that is, I believe, yes, that's my last slide.
Great. Thank you so much, Dr. Hamilton. I am coming back on camera. There I am. So now we're going to take some questions from everybody. So everyone, please do keep in mind the question box is in the little GoToWebinar doodad. So write your questions there and I will read them out. But I am going to start you out with one of my questions. So, you know, we're finding more and more genetic markers for people who have IBD and Crohn's and ulcerative colitis. So how close to being actually able to use those genetic markers are we to being able to say, so this is the type of Crohn's disease or ulcerative colitis they're going to have? Is it going to be moderate, severe, or mild? And or being able to use that to figure out how people respond to these medications. How close are we?
Right. So excellent question. I mean, that's sort of my last slide. I didn't say specifically what these tests of the future would be, but most likely they are going to be genetic type tests. And you know that we were a little discouraged, you know, 4, 5, 6 years ago when a lot of the genetic studies came out, and we sort of learned about all these different genes that were involved in IBD, which was really cool and fascinating. And we didn't have that information before, but clinically it just hasn't really helped us too much yet. There's certain genes that can be used to predict risk of IBD, but they're really not in the mainstream being used yet. There's a company, Prometheus, that's put together sort of panel of these genes, which can be used to predict IBD, but it's just not a perfect test. And to be honest, we don't routinely use it. But you know, the hope is that with time, we're going to sort of add to it and make that a better test. Because I mean, I agree with you. I mean, I think genetic tests can potentially be the future. IBD is considered a complex genetic disorder, so there's hundreds of genes that are probably involved, which is why why we haven't figured this out already. But it probably is coming, and sort of incorporating genes with other clinical factors to predict risk and response to therapy.
Yeah, I know there already have found so many genes that seem to be in play with Crohn's and colitis. So I would imagine it would be really difficult to sort of say this is the one of 500 genes that could be, you know, saying something to us. So
Yeah, exactly.
Understandable. Now you mentioned Prometheus. That was actually my second question for you because I'm going to keep asking questions. So Prometheus does have that test and a number of other tests that they offer to people with inflammatory bowel disease, but they're not covered by insurance. And so I guess I'm curious, like, is there a reason why people might want to do those versus just kind of going with the tests that are still covered by insurance? Is there something that they tell that's different? The other thing too is I think it's also like Coloplast, which is the at-home kit where you get to send your sample off to get tested for colon cancer. I know it's not really indicated for our community. So tell me a little bit about these sort of different tests that are coming out and why would somebody choose them or not?
Yeah, so I mean, I agree. The Prometheus test that is frustrating when that's not covered by insurance, and sometimes those tests are ordered for patients, and the provider may not know, or the patient may not know, and they'll get the test, and then all of a sudden get this huge bill. You know, many of you may have had that experience, but it sort of depends on the provider and the situation in terms of whether or not those tests are going to be helpful for you. I think if you see someone with a lot of experience in IBD, they're going to be able to determine diagnosis and prognosis pretty accurately without those tests. I think maybe sometimes where they're helpful is where you have what's called an indeterminate IBD, where you're not really sure is it Crohn's disease or ulcerative colitis. Sometimes the testing can help in that situation, or when you really are having a hard time trying to figure out what the prognosis of the IBD is and the risk of IBD to determine treatment. Sometimes the Prometheus panel can be helpful, but to be honest, in our center in Boston, we're rarely doing those tests. That's not to say I haven't done them before, but it's just they're not totally essential. Yeah.
Got it. Now, somebody just asked a question, which unfortunately I'm desperately trying to get the rest of it, which is unfortunate. I've never hear very many gastros mention Simponi for use of treatment. Can you tell us a little bit more about that? Unfortunately, I can't see the bottom of that question. It's really annoying.
Simponi is another So it's a class of biologic that we use. It's indicated and FDA approved for ulcerative colitis. So it's another so-called anti-TNF biologic. So we have Remicade and we have Humira, and Simponi is another one. It's also it's like Humira in that it's given by injection, and I believe the maintenance dose is once a month. So it's an effective treatment, anti-TNF biologic for ulcerative colitis. It may be less used just because it's been around. It's sort of the newer kid on the block, and I think a lot of providers just have more experience with Humira and Remicade. So that's maybe why we haven't heard of as much about Simponi.
Okay, it says, what should a Crohn's patient be aware of before going into any type of laparoscopic testing? Laparoscopic. Unfortunately, for some reason, I can't see the bottom of the question, so laparoscopic things.
So yeah, going into surgery, I mean, hopefully it depends. I think most of the time we're doing surgery in Crohn's because there's an area of Crohn's that we're really worried about, or just not getting better with medical therapy, or maybe that area is scarred down. So that's why the surgery is being done in the first place. We do prefer laparoscopic surgery over open surgery. Laparoscopic surgery is where they're sort of going in just with cameras and smaller incisions, and so people heal better and do better. I think that really the key to this is having an experienced surgeon that knows what they're doing. And at our center, we're fortunate to have actual surgeons that specialize in IBD. So they know exactly what to do, where to go, where to look with their laparoscopy. So experience really does matter with surgery when it comes to IBD.
This person asked, could surgery cause more inflammation?
Hopefully not. The surgery is being done to cut out all the active inflammation and diseased parts. And the hope is that when that's done in Crohn's, like for instance, probably the most common surgery that's done is the so-called ileum resection, where that part is removed and put back together, or the bowel, the resection is made and then the ends are put back together. So all the disease has been cut out, and then from that point on, we're trying to just prevent recurrence of Crohn's. So it shouldn't make inflammation worse, the surgery. It should only make it better.
Great. Are there any therapeutic drug monitoring methods for Xeljanz?
Good question. Xeljanz is a newer medication that's being used now for improved for ulcerative colitis. So it's actually slightly different than the so-called biologics that we use. It's something called a small molecule inhibitor. But basically, you don't need to monitor the dosing of Xeljanz. It works very quickly, and one of the advantages of actually Xeljanz is your body doesn't develop an immune response to the drug itself. So, like with Remicade, for instance, and Humira, you may develop antibodies to the Humira and Remicade, and it may hinder that drug from working. Xeljanz, that doesn't happen. So and the dosing, it works very quickly, it wears off very quickly. So we're not going to have to monitor Xeljanz like we do the other biologics. Good question.
Okay, good to know. Yeah. It says NSAIDs aren't very good for Crohn's patients, but if they have other autoimmune disorders like RA or fibromyalgia, what are your thoughts of COX class 2, COX?
Yes, very, very good question. So NSAIDs, you're right that NSAIDs we do worry about for long-term use. NSAIDs, by the nature of how they work, can interfere with healing of the intestine, and that can actually promote ulcers, like you said, and inflammation. So really, the last thing you want when you have inflammatory bowel disease. But also, like you said, a lot of people with IBD can have joint pains and joint issues that need to be treated. Hopefully, get you feeling better. So studies have shown that very, very, very short courses of NSAIDs, like Motrin and Advil, Aleve, used sparingly and in very short courses, days to a week or so is fine. If you need a slightly longer time, then the COX-2 inhibitors like Celebrex can be used safely in IBD. Again, shorter courses though. So, weeks at a time with Celebrex, not months. The longer you use these meds, and if you use them on a daily basis, they're put you at higher risk.
Got it. So follow up to the person when talking about scar tissue, how common is endometriosis and Crohn's for female patients?
Okay, so maybe that was maybe that was the question about laparoscopy. I don't know. I mean, I don't know if there's actually, I don't know if we know that there's that people with IBD have a higher incidence of endometriosis, but we certainly see it. I mean, a lot of people with IBD are young females, and it's something we certainly have to think about when you have ongoing symptoms despite treating the IBD. So, that should have, I could have added that to my slide. What else could be going on to explain symptoms? Endometriosis is a big one. So, oftentimes if people are having pelvic pain, especially around the time of menses, and we do have, work with the GYN, or consider things like a laparoscopy to assess for endometriosis. That's a good question.
When a temporary ileostomy, what signs do you look for to know that it can be reversed? If there is some inflammation in the colon, is it safe to do a reversal?
Yes, that's a tough question because it's not always easy. But we always would like to reverse an ostomy if we could, and restore confidence, so to speak, and internalize everything again. Sometimes it's not possible. Most often it's when people have inflammation that's ongoing in the rectum area, because usually that's where the surgeon wants to reattach things. And if there's disease down there, if there's scarring or fistulas, what happens potentially is that when you reconnect, that all that rectal disease or perianal disease, wherever it is, could get worse again. So, the instances where we can reverse an ostomy are when we know the IBD is completely treated, there's no evidence of ongoing scarring or fistula, and that's we're going to very carefully monitor things, once you're reconnected. So it can be done. Everything has to be lined up and monitored very carefully.
Okay. This person says, with sporadic flares that are controlled with corticosteroids that induce clinical remission, is it better long-term to be on a biologic? How do I weigh the risks and benefits?
Yeah,
I guess
so
she's maybe asking, when do you go from just using steroids to deciding a biologic is a good?
Yeah, so if you need steroids, and if you're it sounds like you're having flares which require steroids, that's usually not a good thing for two reasons. One, you're flaring, and every time you flare, you have symptoms, and which has all the downstream effects, miss work or school or whatever. It also puts you at higher risk for complications with your IBD when you're flaring, every time you flare. And then every time you go on steroids, that's also not a good thing. I mean, all of this side effects of steroids, the effects on bone, on your skin, on your eyes, these are all bad things about steroids. So when people are flaring frequently and requiring steroids, it sort of bumps you up to a more severe category. And we really do want to get you on something like a biologic to hopefully get rid of that need for steroids and prevent flares and keep you in remission. So I would say that our biologics nowadays that we're using in 2019 are safer than steroids. So yes, I would say in your case that I would say that the risk of your steroids and IBD is higher than risk of biologics. Absolutely.
Okay. So there's two questions. I'm gonna roll into one for the very end because it's a big topic. But this person says, is there any way to know if someone will respond to an anti-TNF versus an integrin blocker? Can't you test level of TNF as a guide?
Yes, so that was in my IBD of the future. We can't yet do this. So I mean, this is exactly what we want to do. So if you have some, let's say you are diagnosed from the get-go with ulcerative colitis, and it's a pretty severe form of ulcerative colitis, I can't tell you that Entyvio is going to really work for you, or Remicade is going to really work for you. So, an anti-integrin and anti-TNF. But we just don't have that test yet. And like I was saying earlier, it's sort of trial and error. We typically go with the one that we think is going to work best for you, but we don't always know. So it would be nice to have the test. We don't have that test. So, the tests that you're saying that we do have, like the testing levels of anti-TNFs, those are only really good, once you're on the drug, to tell us that you're basically getting the right dose of the drug. That's all. Those tests are helping with. They're not telling us whether or not you're actually going to respond to that drug, unfortunately.
Yeah. Okay, so this is the question. So what are your thoughts on non-RX treatments or supplements to reduce symptoms? So things like probiotics, herbal treatments, turmeric, acupuncture, meditation, CBD.
Yes, every single webinar, patient seminar, there's always a question about this. It's a very, very important question because we like these therapies. And I'm sorry I didn't talk about it on my slides, but we do consider these therapies to be more complementary to what we're doing in the clinic with our other medical therapies. So we consider the biologics and immunomodulators and salamine and the other things I did mention as the sort of more standard of care, tried and proven and proven in clinical trials, et cetera. But there are these other therapies that you say they do exist, and they are for the most part helpful, and they're complementary to everything else we're doing. Meaning that, again, I don't think they're going to hurt, but oftentimes they do help you. So we do suggest potentially doing them, especially if you're having ongoing symptoms, symptoms like chronic pain or chronic nausea, appetite issues. A lot of these things like CBD can be very, very helpful. Turmeric is an excellent anti-inflammatory. It's very safe. You have to take higher doses than you're probably going to use on a standard cooking dish. I mean, sometimes it's something like 500 milligrams twice a day, and even higher. Probiotics, sort of mixed results on probiotics. It can be helpful for ulcerative colitis. It hasn't really panned out as much for Crohn's disease. We didn't talk about fecal transplants. It's another therapy that is being tested. May be more helpful for certain people with ulcerative colitis, certain subsets. Again, it would be nice to know up front with testing whether or not someone would respond to something like a fecal transplant. We just can't answer that right now. So it's sort of still investigative. But and the other big one, and probably the best complementary therapy is diet. And I think we're going to see a big emphasis on this in the next decade or so is dietary therapies for Crohn's and ulcerative colitis, actually. Right now we just sort of talk about diet in more broad strokes, that something like the Mediterranean diet or the specific carbohydrate diet are probably the best diets for IBD. But we don't know specifically what people should be doing, and maybe it may be different for depending on you and your IBD and what type of IBD you have. So there's a lot more work that has to be done in that area. But again, I tell people Mediterranean diet or specific carbohydrate diet. Avoid things like sugar and other things like preservatives, processed foods, all that crap that's in our Western diets that are probably inflammatory, probably bad for us. Be healthy. Don't smoke cigarettes either.
Right. Well, we have a few more questions. So some of these questions are a little bit long, so I'm going to actually take those offline and send them to you directly. But okay. I want you to end with this one because this is a fun one. Are there any new therapies on the horizon and anything that's exciting and new that's different than what we have that you're looking forward to?
Yeah, I mean, I think there are a lot of, I don't know, I don't want to be pessimistic, but I think a lot of the therapies that are being developed are the biologic type therapies. I think it's big pharma, and there's a lot of money to be made. So a lot of the focus, as we've seen in the last decade, has been a bit on the biologics. We do want to figure out better ways to treat moderate to severe IBD, and the biologics can be great therapies for that. But a lot of the biologics that are in the pipeline, they don't seem to be as, there's no like sort of game changer that's out there yet in terms of a biologic that's going to help. And then they're all targeting different mechanisms. We're hoping for that, drugs that are more efficacious and safer in terms of the biologics. And the other therapies, like I said, I think dietary therapies, I think we're going to see a bigger emphasis on those in the future. And then the ways to target the microbiome. So maybe not a fecal transplant, but very specific targeted probiotics that are doing the same thing as a fecal transplant and maybe even doing it better. I mean, I think that's going to be exciting also. Again, we're hoping to see that within the next 10 years as well.
Great. Well, thank you so very much. You ended perfectly on time, so that's fantastic. Thank you so much, Dr. Hamilton. This was really, really interesting, and I appreciate all the great questions from the audience as well. You guys asked some really good questions, which of course I shouldn't be surprised by. So thank you again, Dr. Hamilton. We're so appreciative of this, and thank you everyone for coming tonight. And again, thank you to, speaking of pharma, UCB for being our sponsor of this webinar. So I hope you all have a great night. Thanks again. Bye, everyone. Have a happy IBD Awareness Week.
Yes, thank you, Alicia. Okay.
Bye.